So this session is something really different for us. It's around physiotherapy data. And Alice and I talked with Euan a few weeks ago about putting a session on around physiotherapy data and the work that he's trying to do to manipulate it to get better use of physiotherapy data and involve the professions in better use of physiotherapy data and how that might interact with groups like us. So I shall let Euan introduce himself. He can go through I think he's got some slides you should be able to share, Euan. And then we'll get into the discussion after that. Is that okay? I'll let you introduce yourself and give you the background as well, Euan.
Yeah, thanks, Chris, and good morning, everybody. It's great to be with you. Like I said, I'm definitely in the right room, kindred spirits interested in proper, meaningful, useful, and safe use of data. And that's exactly what I want to talk to you about this morning. The presentation is called Data and Physiotherapy. So we will be looking at it very heavily through a physiotherapy lens, but also it would be great to have a thought in the back of your mind about actually this is going to be really pretty applicable across different professions and their use of data as well. So my name is Euan, like Chris said. I am a physio by background. I've been qualified since 2007. I worked in Scotland for a number of years. You might have picked it up from the accent already. And in various clinical roles, mostly in rehabilitation. So orthopedic or neurological rehabilitation were my clinical specialties. But I've been working in health informatics, data, digital technology for the last 12 years. So mostly in trying to make the best use of technology, safe and efficient, to improve the delivery of physiotherapy services. Initially in Scotland and now working across the whole of the UK and working a wee bit internationally now as well. I work for an organisation called the Chartered Society of Physiotherapy. So the CSP are the professional body, educational body, and trade union for over 65,000 members of the physio profession across the UK. The biggest chunk of that is our registered workforce, our physiotherapists, but we also have in our membership support workers, students, lecturers, and retired members, as well as some international members. So like I said, 65,000, vast majority of which are in the UK, but there are some who are living overseas as well. I'm going to share my slides now. Chris, I'm happy to share them with you and for them to be disseminated to people on the call after the event. That's me there. That's what we're going to talk about. So let's move on. I've already dropped in health informatics. It's not a familiar term to a lot of people within the physio profession and outside it as well. So I just want to start off with some definitions. In healthcare and in normal life, health informatics and digital are used interchangeably, although digital is more common. But it's important that we understand the subtle differences between the two terms. So digital health is more focused on the devices and the systems, whereas informatics also considers the exchange of knowledge, information, and data, as well as the tools with which we do that. So that's why I prefer to use health. And I should have said before I start, if there are questions, pop them in the chat or just interrupt me. I'm absolutely fine with that. So yeah, like I was saying, I prefer the term health informatics. I'm a bit of a purist, a bit of a pedant, because it is the more complete terminology, if you like. I will trip up over that, and I will use digital by mistake. So please correct me on that, and then refer me back to this slide when I do it. But the one bit that's missing from both of these definitions is people, and without people, even the most impressive piece of technology will not have its optimal impact. Healthcare has and always will be reliant on people to support the use of technology and providing better services to those who need it the most. And in my lifetime, I cannot see a physiotherapist being replaced by technology. However, a technology-enabled physiotherapist will absolutely replace one who is not. And the problem about the use of informatics in physiotherapy right now is that it's usually the exception rather than the norm. And one of the reasons why it's not the norm yet is that we just don't have the right quality and quantity of data to use to define why and where we can use the technology. Now, to have any impact on change in healthcare, you need data. It's the currency of change in healthcare. And when I talk about data, I don't just mean stats. I mean any meaningful intelligence that we can gather. That can come from many sources, many different styles, but it has to be collected well, used well, and then shared well. I speak to loads of members of the physiotherapy profession and other professions in health and social care across the UK and further afield. And across the 12 years I've been working in informatics, I've never met anybody yet who can comprehensively answer those questions on the screen and comprehensively say yes to all of those. And that's even though the data is generated at all points in a patient's journey. But at least in it, somewhere along that case, we're not collecting it systematically, or we don't truly understand what it means, or we don't consume it as much or as well as we create it, or we don't use it to drive improvement in services, or we don't use it to demonstrate the impact that our service is having on other bits of the health and social care service, on the patient themselves, on their health and well-being, on their activities, on what they're able to do in their day-to-day life. And without good quality data, we're not going to be able to define our services, test the changes that we want to deliver, nor demonstrate the impact of the change that we're trying to try to deliver as well as we'd like to do. The statement in red at the bottom of that screen is pinched with pride from a good friend, Dr. Leslie Holdworth, OBE, who said that if you don't count, you don't count. So the first thing that I'm trying to do within the physiotherapy profession is to find a way to make sure that all of us count. And why am I wanting to do that? Well, in 2019, NHS England planned to deliver, as they called it, data-enabled AHP services. And that was in a document called the Digital Framework for Allied Health Professions. Physiotherapy are one of 14 allied health professions in England. Other ones, occupational therapy, dietetics, speech and language therapy, radiographers, paramedics, and others, but I can't remember right off the top of my head. But there's 14 of us. So there's a desire to get towards that, and that was painted by NHS England 5 years ago. A couple of years back, the CSP conducted a survey of community rehabilitation services across the UK. 40% of those respondents said that they didn't submit any data to regional or national data sets. They may have been collecting stuff and using it locally, but we weren't making the most of it at regional and national place. And then of those 60% that did submit, nearly 20% of those people never received any data back. So I don't know what would frustrate me more as a physiotherapist, not having the data to be able to use in my service, or spending some time and money, resource, energy to be able to collect it and submit it somewhere, but not getting anything back to let me know what I can do with that data, how I can use it. So later on that year, myself and a few others conducted a survey of UK AHPs and looked at their digital competence. So starting to unpick a little bit what it was that the allied health professionals needed to be able to get involved in digital and data. And we're going to talk a wee bit more about this. So 19% of the people that responded to that reported low competence in data management. This was self-reported competence. And it was against a document that you see in the top right-hand side there, a UK AHP digital health competency framework. Worryingly, also 42% reported low competence in records, assessments, and plans. So we're not managing data well, and we're not quite sure how to use the systems that we have in place already. They may be electronic systems, they may be pen and paper, and those big ugly files that you've seen in your GP service probably. We're not making the most of those. Again, self-reported competence in that area. So we're not where we'd like to be. We're not where NHS England wanted us to be when they released that digital framework for AHPs in 2019. I said earlier, there are exceptions to that rule. There are some places who are using data really, really well, and I wanted to highlight a couple of those. So those of you who are lucky enough to live in the southwest of England and Dorset have this brilliant service called the DICE, the Dorset Intelligence and Insight Service. And what that is doing is linking together multiple sources of health and social care in a safe and efficient way to give actionable insight to local population needs and our service impact on those. So if I'm a physiotherapy service working within Dorset, I can see and demonstrate the impact that my service is having on other parts of the health and social care system and on population health. And it can let me look in and see, am I getting the right people that need to see me coming into my service? If not, why not? Then we can start to get into some, into the real kind of minutiae, into the detail around health inequities. And that's a super important place to use our data. Another place and another person that's doing amazing stuff is Helen Robson. She's on the left-hand side of your picture there. She works with an organisation called Connect Health. They're largely private and independent sector, but they do quite a bit of NHS commissioned physiotherapy as well. And Helen is the brains behind a brilliant dashboard of all Connect physiotherapy services across the UK. That's over 850 staff, over 150 sites across England, and they're starting to dip their toe into Wales a little bit as well. Their dashboard is not all that complicated, and that is absolutely not a slight at Helen and her team, because data doesn't have to be complicated. Data just has to work and work well, and it does. And they use it to drive their services. So again, there are people who are doing brilliant things, but there are also people who are looking to do and want to do a little bit better. And that's why at the CSP we have worked over the last few years to try and address what we now know is this gap, this deficit in data and in data expertise. So in November 2022, we launched the Physiotherapy Health Informatics Strategy, or the FIS as we call it for short. We started off by conducting an international literature review and a gap analysis of the published information available to the UK physiotherapy population. We used the digital competence framework that was published by NHS England, as well as that 2022 survey of UK AHPs that was published by Chris Tack, myself, and others. And what we came up with was the FIS. So the FIS is there because there are some other documents in the space. There are very many of them, 300 plus that I looked at. And some of them pitched this vision of what informatics-enabled healthcare services could look like. Some of them focus much more on the knowledge and skills that people needed to have to be involved in technology. But nowhere really did all three at the same time, and nowhere did it for the physiotherapy profession specifically. The CSP is in the perfect position to do that, and that's why we launched into it, and we launched the FIS in 2022. It's comprised of 3 sections. We have the vision. So this is what informatics-enabled physiotherapy could and should look like in a perfect world. There's the education. So these are the knowledge and skills that the members of our profession need to have to make the most of informatics within their services. And then what we call the critical glue in the middle is the practical application. So how do I use those knowledge and skills and apply them in my service so we can aim towards the vision that we've pitched for people? The vision you see on the right-hand side there, it's a bit complicated, and that is exactly why I'm sending the slides to Chris, so you can consume that in pieces rather than all at once. But I wanted to demonstrate our thinking within it. It is meant to represent every member of the physiotherapy profession across the UK, regardless of your sphere of influence. So if you're working as a relatively newly qualified physiotherapist, for example, or a support worker as part of a service delivery, then your sphere of influence might be more at an individual level, but that's absolutely fine. Here are the things that we could use informatics in to improve the service that you're part of, and their part in leading that. If you're working at more of a leadership role, maybe in a management role, then you might have more of an organizational influence. And these are the things that you're able to use informatics to drive. And if you're working in a national role, then these are the other things that you might be able to do as well. Cutting through the middle of all 3 of those spheres of influence are the core elements. And they might look a wee bit different depending on what your role is, but every member of the physio profession should be using or considering informatics, how it could work in terms of their leadership skills, education skills, and inclusion. And then surrounding all of that is this informatics culture. So as we make little bits of change, then the next piece of change doesn't feel quite so difficult because we've already got a mindset shift to understanding and using technology a little bit better, or we've made networks with people, or we're really understanding our data more. So it makes us, it makes the next challenge or the next improvement project that little bit easier. So that informatics culture grows exponentially as we make improvements. We've launched the vision The education stuff I want to talk to you a little bit more about, and the practical application stuff is going to be coming through 2025 for our members. So we have the QR code at the bottom right hand side there takes you to the pages on the CSP website, and they are purposefully open to all. So even if you're not a member of the CSP, you're able to look and see what we're doing within the profession to try and use informatics to improve our profession and the services that we provide. So the education bit, I'm going to share some stuff with you here that is not commercially sensitive, but I would appreciate a little bit of candor in terms of how we might share that. I'll talk to you later about that, Chris. But CSP was commissioned by what was HEE, so Health Education England, now NHS England, as they've merged. And what they gave us was just short of £50,000 for a 6-month project. So most of that was paying for CSP staff time. We also commissioned an HEI partner, a Higher Education Institute University partner. That was Keele University. And we also were able to collaborate with partners from multidisciplinary teams. So we had 11 of the 14 AHPs or representatives from them as part of that project. And what we're looking to get is, over the next couple of weeks, a further £70,000 for the next phase of that, and we expect that to be happening pretty soon. The first commission of £50,000 was to create the raw content of an education resource for allied health professions, based on what we'd found in the literature review for creating the FIS, but then working with our MDT partners to make sure that we were including all of them and not using language that would only work for in the physiotherapy profession, for example. And I'm going to talk to you about exactly what's involved in that education resource. But it is to try and address what we found in those self-reported competency gaps to try and upskill everybody. Our target audience are all AHPs across the UK. Emphasis on all. So any country and any setting, specialism, or any employer. So we are also including those in the private independent sector, those who are working in education and others. And emphasis on the all as well. This is commissioned by NHS England, but you can tell by the accent, I'm a Scotsman, I live in Northern Ireland, and so I couldn't let the English have all the fun. So this will be accessible to all AHPs across the UK. They don't need to have any previous knowledge of health informatics. It's absolutely fine. What we're trying to do is create this foundational level learning to raise the lower bar of competence because then we're going to have the biggest impact across the biggest number of services. I'll come to you in just a second, Francesco. We do need our learners to be minimally computer literate, because it's an online resource, so they will have to be able to access that to then make the step into it. But they will have to have a minimal level of computer literacy to do that. I'll pause for a second and come to Francesco. You have a question?
Yeah, thank you. In all fairness, I presume that you're talking about Northern Ireland, Scotland. Is this right across all the devolved nations as well?
Yes.
Okay. Observation, okay, and it may well be that the Chartered Society of Physiotherapists are not all that, because I don't hear the voice of users of physiotherapy services. So in that respect, I don't know whether or not you have lived experience. But when you look at the statistics from the Department of Work and Pension for England, I can't speak, the second biggest group behind mental health disorders are musculoskeletal. Now, that tells me something. Looking at, there, and that is about half as many as what there are with mental health issues. And that's about, for musculoskeletal, that's 600,000. Now, I'm kind of like thinking of those that you may not have a reach towards, which would be those that are employed and they got occupational health services, and they have, maybe a couple of physiotherapists. But in terms of, no disrespect, in terms of impact from physiotherapists, whatever their research may well be, what their primary outcomes or secondary outcomes would be, they're a little bit in the woods in some ways, because if everybody started trying to access data, patients or people would start nationally opting out fully, not partially. So I think you need to look at your own communication strategy, because if the occupational therapists, the clinical psychologists, and all the other 13 groups went down the same road as you, it'd be a bit confusing. So, I think the more research there is that you can show through dissemination, like you may be familiar with the research being done by the University of Birmingham, Joint Works.
I'm not, Francesco, I'm afraid.
Now, that's looking at chronic musculoskeletal disorder. I'm on the advisory group on that one. But from what I can see, is physiotherapy or the society, trustworthy? Hard to answer that one at the moment, because it hasn't actually it hasn't left much of a legacy over the years where people could say, hey, yeah, they've got a good, they've got a good outlook, they're looking after the patient. If you haven't got patient partners on board with what you actually do, it's hard to get that narrative out there, because then it's about what you want, which is your focus, and not necessarily the patient or carer. It's just an observation. Okay.
No, thank you, Francesco, and it's a fair observation. The reason that I'm here today, or one of the reasons I'm here today, is to try and get even more of that patient voice into what we're doing. So absolutely want to hold that thought, and that I'm going to come back to that a wee bit later on in the slides. One of the other reasons that we're doing this work is absolutely so we can get better data, so we can be a stronger and louder voice. So we're saying this is what we are doing, this is the impact that we are having. And then we can demonstrate that to the public, to say these are the things that we're doing well, but equally these are the areas where we'd like to do better. So these are the areas. So the prevalence of MSK conditions is one of those things. The numbers are continuing to rise, and physiotherapy is not meeting that demand. Let's be brutally honest. Is that because the physios are bad? I'm going to be a little bit protective and say no. It's because there's not enough of us, and or we're not doing the best things to be able to try and address that increasing demand. But how do we fully understand that? We have to have better data to be able to understand that. And part of that is about our met need and our unmet need, but it all comes back to that data point. So I totally hear that observation, and I'm not defending or protecting my profession, because we're as imperfect as everybody else is in that matter. The other thing I was going to say about working with other professions is this is properly collaborative. So this is us working on behalf of the 14 professions. So we are working hard. So this isn't just a physiotherapy thing. We might be quarterback, if you like, in terms of leading the project, but we're working really collegiately with other professions to make sure that this is something that can be accessible by all allied health professions, and that's upwards of 200,000 healthcare professionals across the UK. That increases the impact that we're going to have, the breadth, the depth that we're going to have at. So I totally hear that observation. It's a really fair one. Anthony, you've got your hand up as well.
Yeah, I was just going to say it sort of goes back to what Francesco just said, but I think from your point of view, health informatics is a relatively new strand of knowledge, and that has to be understood. Partly going back to what you said in your previous slide, like you don't know what you don't know, and if you don't count, you don't count. So that is slowly but surely being addressed as projects like this start to show, it's show and tell, isn't it? Basically, a lot of people need show and tell. It's like, this is what we've been banging on about for the last few years. This is how it makes a difference to your reality as a professional reality and your patient's reality. And there has to be show and tell, but the only way you can do that is by doing projects like this, which basically do that. I think the other thing is, like, although you might sort of assume that somebody at a certain level of competence would be computer literate, that ain't necessarily so. And like what somebody thinks is computer literate might be like, oh my God, this is way beyond my comfort zone for somebody else. So bringing everybody up to the same level is the first job, and then getting them to understand the language of health informatics. I mean, you can go online and do degrees in this. You know, that is a thing, but most people haven't got 3 years to wait. Do you know what I mean? They need the information and they need to sort of start implementing, you know, relatively quickly. Going back to what Francesco said about PPIE, once again, this is a brave new world. And once again, it's show and tell. This is what the patient voice can do for you. And then we move on. So it's what I call nudge theory, but actually that's how it is in reality. You're nudging all the time, but eventually you've nudged so that we're in a much better place. And it's always looking back. It's like, look, where were we? Where are we now? And that's the important bit. So it's just nudge, 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 and then everybody is in a better place. Patients, practitioners, and the overall NHS. So that's all I wanted to say.
Yeah. Thank you much for the comments, Anthony, and really well made. This is nudging. You know, that this is trying to bring everybody up to that, you know, to a starting point with health informatics. It's foundational level learning, it's base level skills that we're giving all of our practitioners, and then that is then able for them to make those small changes within their practice that improves the service that they're delivering to their population. And like you said, that nudges up and nudges out. So we're starting to have that impact. Is it going to be immediate? No, it's not. It's going to take a bit of time to do it, but we have to start somewhere. Like you said, there are things that you can do online, health informatics, master's level degree courses, and all sorts of fancy things. That's all very well and good, but where do people start from? And it's a starting point that we're working from. And I'm going to show you in a minute about the content of the course as well, so you can see that we're starting to drip feed in. This is just the correct way to do that. And one of those things is how do we co-produce with our service users? That's one of the learning bites. And we start to drip in. I can't remember. Apologies, Anthony, if it was yourself or Francesco had said about bringing in the most recent research. That's exactly the sort of thing that we're starting to do. So we're starting to give people the tools with which they can continue on their learning through health informatics to improve better services, or to provide better services. So and the aims of the course on the slide there about activating our learners, and that's exactly what we're doing. Our learners are our health and social care practitioners. We're activating them so they can use health informatics to be able to have better data, use it, share it well, to then deliver better services. It's what we're trying to do, and it will take time. That nudge theory is a really important thing. I'll take Brenda's question, and then I'll maybe jump on again.
I'm just wondering whether you've got any move afoot to get systematic replies from patients, perhaps a questionnaire, perhaps including whether they felt their benefit, and also reasons for non-adherence, or whether they've adhered to it, and reasons for non-adherence. And I think this is particularly important with physiotherapy, where there's not such a direct measure of whether it's been successful or not, as in other medicine. Just to say, I'm a great believer in physiotherapy, so I've had excellent service, and it's really made a difference. But I mean, one of the things that, for example, and I think this is what's missing from what you've said before, it's examples of how this affects the patient. Just for example, what's put me off doing exercise that you might see on television is, am I doing it right? Am I likely to do myself more damage? And I think this is the kind of thing, if you could find that, it's about patient and public involvement, but not in a small term, almost in asking every individual, every patient that the physiotherapist sees. And as you say, collecting that to national, because you're not going to get everybody with the same response. But I do think this is important. And it's very difficult to get to see a physiotherapist, as I've as I found. But it's so important that the times that the individual spends with the physiotherapist is maximised and we get the best benefit out of it. So the question is, are you currently doing anything about collecting information from the patients?
Short answer is yes, and lots, but we want to do more. So hold that thought as we look at the content of the education course, because we absolutely dip into that. And it's it's a nuanced area around about patient experience, because one person's experience and other person's experience of the exact same service can be completely different. That's human nature, right?
But that's what you need to find out. Why?
Absolutely, we need to dig a wee bit deeper into that. And also, you can have a positive or negative experience, but be satisfied with that. So, for example, if we were working with people with a chronic degenerative condition, for example, their experience might be actually negative, that they're able to do less by the end of the spell that they have with a physiotherapist, but they might be satisfied with that because of the education that we've been able to give them, because of the workarounds that we're able to get. So, it's a nuanced area and it's so individualized. So yes, absolutely. Again, hold that thought for when we think about the content of the education course, because data is not as simple as, did it work, yes or no? If it was that this would be really easy, I probably wouldn't be in a job. But it's nuanced, it's individualized, and we have to get it right. We also have to think about how we compare that, because you can't really compare your apples and your oranges, because it'd be unfair to do that, because everybody's so unique, so human. So
it depends on the quality of the questionnaire, doesn't it?
Absolutely, and how it's asked and how it's presented. If it's presented on a tablet and somebody doesn't have the digital competence to be able to use a tablet, then that's excluding somebody, or they don't. They're not able to get out to a post box to post a handwritten thing back or whatever. There are so many layers that we need to think about. So we're thinking about, like I said, the best way to do it. So hold that thought, Brenda, because we're definitely going to come back into that. Just to finish off on this slide, the other thing that we need to think about is bringing people together, because there are 65,000 members of the CSP, 200,000 members of allied health professions across the UK. But it seems like, or it sounds like, from what I hear from people, that people are doing some really good stuff in their pocket of the UK and their profession. Then who do I reach out to share, to learn, to share the challenges I'm having? And it can feel like you're plowing a fairly lonely furrow at times. So we want to link people together so we can share it, so we're not replicating where we don't need to be doing so. So what does the education course look like itself? There's an introduction module at the start of it. It's module based, I should have said. There are 4 modules. Introduction is the first one. Every learner accesses through that. That gives us the definition of health informatics. It gives us how the course is going to work, how the platform works, so people land within there, and then they go out into any of the other 3 modules that they want to do. You'll see there from the bubbles that are coming out of those 3 modules: data, digital service delivery, and improvement and innovation. Some of the bubbles that you'll have recognized from the Phys Vision, if you were paying attention, on the first couple of slides. So we're starting to see where the breadcrumb trail is coming through, the research of how this has got to be. The next slide is difficult, and again, this is why I'll share the slides with Chris, and he can share them on to you all after this. These are what the modules and the learning bites look like. I said earlier, the course is module-based and it's bite-sized. So each of these learning bites will be a maximum of 15 minutes of learning for our AHPs. So overall, that's about 8 and something hours of learning. We don't expect them to do that all in one go. But they don't have that time to devote, because services are just so overwhelmed at the moment. So this is meant to be consumed bite-sized. Like I said, everybody enters at the introduction, and then they're able to go to whatever bite is the most interesting to them, or the most challenging to them, or the most burning part of their their service at the minute. To go back to your point, Brenda, which you made really well earlier on, about measuring performance of my team. So bite 3.6 is where we start to feed that in. There's also quite a bit around 3.8 about measuring satisfaction with my digital service. So performance and satisfaction are subtly nuanced different things. We spoke about co-designed with users and other stakeholders with Francesco and with Anthony. There it is in there at 3.7. We spoke about how do I make our service more inclusive and using technology or not, and that has to be different. So we're thinking about 3.4, how do I make my service inclusive? And then when I joined the conversation just at the very start of this morning, we're talking about federated data platform, and my goodness, that is such a big issue right now. But we're starting to think about how that actually works in practice in our data module, so 2.1 to 2.7. And we're starting to think about how I use my data, how I use it safely, how I store it safely, how I share it effectively and safely as well. So we're giving our learners these tools with which they can start to have that bigger involvement. And then when we come into our module 4, improvement and innovation, we're starting to think about how I use that wider. So Francesco, you spoke about how we're using it to drive research. 4.2 is where we're really starting to get into the bones of that one. And we're starting to think about future proofing as well, so 4.6. But there's loads and loads of content in there. The language that you'll recognize is purposefully individualized. So it's, how should I collect data about my service? So we're not wanting our learners to be passive in this. We're wanting them to be active. So they're driving change within their services. So then we're starting to get that nudge effect that you spoke about, Anthony. So we're starting to reach out into all corners of people. And we want to also think about the people that we're not seeing. But the first step of doing that is really understanding who we are seeing. And then we can understand through public health, involving things like the DICE, who we're not seeing, why that is. And then we can get into addressing some of the health inequities that we know are in place in our services, but they're difficult to address. Data is critical to us starting to do that. How we've come about getting to the point where we've got these modules created, we've got these bites created. It's not been a quick process. It's taken us, 6 months that NHS England paid for, but actually we've been working on this for a couple of years. Yes, started off within the physiotherapy profession, and then we've been working really hard laterally, certainly in the last year, 18 months, to try and broaden it out into other allied health professions, into the other 14. You can see how we've done that, but right at the heart of that has been our expert advisors. We've had expert advisors from education, from the informatics world, from the physiotherapy world, and from all the other allied health professions. What we've not had as much of as we'd like to date, we've not had that patient and public voice, and that's why he said one of the big reasons why Chris invited me here to speak with you all today is because we want to get that as we move forward onto the next stages. We have had patient involvement through the CSP, PPIE, and that's been good, but we want to reach out and to get that a little bit broader. The expert advisors that we have had have been critical to our success so far, and we expect them to be even more critical as we move on to the next phase, and that's where we hope that you may be able to come in. So that's why we contacted Use My Data to say, is there somebody that could come along this journey with us and be part of our multidisciplinary team? On the group already, we've got, as I said, we had 11 of the 14 allied health professions joined us as part of the first phase. We're now up to 13 of the 14 allied health professions. We'd love to complete our set and have a digitally minded art therapist join us. That would complete our 14, but we're delighted to have our 13 representatives already. What we're looking for is an engaged and enthusiastic patient expert to join our group and to share their expertise. Their role would be to review outputs from the design agency that we spoke about ahead of our launch, which will be early in 2025. And with other members of that multidisciplinary team group, they're going to feed back on the content, the style, the wording of those learning bites. Not all 24 of them, because that's a heck of a lot, but on some of them, and then we can continue the themes across the other learning bites as well. They'll also be part of supporting the CSP Phys core team in launching the resources, and we hope to launch them, as I said, in the spring of 2025. The meetings that we have will be 60 minutes max. They'll be virtual, likely on a monthly basis over the 6 months of the project, again, which we expect to start over the next month or so. There might be little bits of work in between looking at different things, so we would have contact by email to request that time and expertise from our members. Now, I'm aware that I've thrown a whole lot of information at you at pace, pretty quickly and in a Scottish accent. So there's lots to unpick in there. That's why I'll share the slides with Chris. He'll share them on to you and the recording will be available. But I'm also very happy to pause for a minute and to answer and to pick up any questions that you might have. For now, thanks very much for listening. I'm going to stop sharing so I can see you all, and then I'll pick up the questions now. There we go. Francesco.
Thank you. This is fact, okay? I undertake stage 1, stage 2 reviewing for NIHR applications, as well as supporting pre, full and advanced doctoral research fellowship. So like you, I use data and fact. And the one thing that hasn't changed over the years, in terms of success on a stage 1 application, being invited to submit a stage 2 or get an interview up in Leeds because you're pre, full or advanced doctoral research fellowship, it's kind of like gone the distance. You've been invited to an interview. It's a allied health professional, whatever you want to call yourself, in terms of applications through what was the HEE and the NIHR Integrated Clinical Practitioner Academic Program, they have the lowest success rate. They haven't got the same degree of savviness as researchers do. Qualitative, they've got better structures to understand what an application should look like and have them peer review so they can be more successful and be invited. The first thing I would say to you, great, have all your people, but I think you need to get a subgroup to enhance or improve the success rate of such applications, because when I look at such application, it doesn't make the cuts. And unfortunately, I should imagine nurses, midwives, and other allied health professional might get despondent. I don't know if that's something that you're aware of, but this is my experience with all the previous year, the chair of each funding committee would produce a report showing, that dentistry, doctors, nurses, they're 40% invited to stage 2, but the allied health professional group, they tend to be below 30, hell of a lot lower. So I'm just saying, I think you need to be looking at that if you want to move forward personally. Okay, thanks.
Yeah, thanks, Francesco. I mean, that is pretty damning statistics. That's pretty damning data. As a lover of data, we can't move away from that, and it's something we need to address. Is that partly to do with the informatics competence of allied health professions? I don't have the data about nursing, midwifery, medicine, or dentistry or others to compare and contrast, but it's fascinating, and I think it deserves extra, more exploration. We need to. And I'm employed by the Chartered Society of Physiotherapy to do this work for physiotherapy, and commissioned by NHS England to do it for AHPs. So that needs to be our focus for now. Could this kind of thing work for other professions? Probably yes, but there's definitely something in what you say, Francesco, of a need to improve the quality and quantity of data driving allied health profession research. So there's something certainly for us to drive in there.
Just to throw in there, and it won't apply. The Health Data Research UK, they've got a fund of money, and they use Section 158 and 159 of the Quality Act to engage with black interns to train them around data science. It's got nothing to do. Although it's a positive action initiative, it's not offering them a job, but it's putting them on a level playing field so that they can, apply for posts that may come up with them or with the British Heart Foundation, Data Science Centre, or wherever. So there's various initiatives out there. What I would say, if you had a pool of, people that could peer review, you know, your colleagues' applications to support them. Because in the real world, outside of your organization, what used to be known as the Research Design Service, but now they're called the Research Support Service, they've got a pool of money that they can give researchers to bring about a focus group with people like myself, Anthony, Fran and others, to actually critically appraise such application before the submission date, so that it can look at, you know, valid informed consent, patient information share. I appreciate this might be moving away from what you're actually after, but believe you me, people have got here today have got transferable skills. So today it's all data driven, but they have got other skills that would support your colleague. Because I'd like to see, you know, because you don't get the same consideration as what the NIHR would do. You may have got a bit of loose change from the NIHR Digital Academy, but all the others, early grade researchers, they know how to actually get support in terms of supporting their application. There are so many different avenues, you know, with the various different schemes that are out there. And it's like anything else, information is power. So the free schools of the NIHR, public health, primary care and social care, they've got a £10 million pot to look at prevention across the main conditions that incurs the greatest amount of morbidity and mortality. So it's looking at people, but I don't know, I'm part of that as a public representative, but I know what I'd like it to look at, but you know, it very much depends how your strategy or your ambitions align with some of that other stuff out there, because you have to talk the talk as well as walk the walk once you've read the script of what's required, if you're looking to get put a bid in for £1 million beyond a feasibility study. I'm sorry if this is all known to you, but this is from a patient carer perspective. I'm sure you're familiar with all that. I'll leave it there. Thanks.
Yeah. No, thanks, Francesco. And you know, there are members of the CSP who've got a professional network within it called the Physiotherapy Research Society. So they would be the ones who are the most active, and they're probably the ones that you're seeing the smaller number of applications through NIHR or HDR UK or other resources or other places to undertake that physiotherapy research. There's not as much as we'd like, because, and one of the reasons we think is because we don't have the data to be able to explore, to be able to understand, and then pinpoint the areas that we do need to do more research. And like you said, knowledge is power. What we're trying to do with this work is trying to broaden up that knowledge, so that then we can use it to drive the change that everybody wants to see in physiotherapy services.
Okay,
but yeah, thanks for that, Francesco. Just looking at the time, we've got about 7 minutes left, Chris. Yep. Anthony. So if there are other questions, pop them in the chat. Another thing I can do is I could respond by email at another date. So if you do have another question that we don't get time to, please put it in the chat, and then I can bounce back after the meeting. But Anthony, apologies.
No, it's fine. So yeah, I think with all these things, it's like Rome wasn't built in a day. And you've got to take the first thing to do is to realize that you've got an issue, and then what are we going to do about that issue? And I think that the particular issue that you're addressing here today is raising the education understanding, not education level, but raising the education understanding of all physiotherapists, so that they understand the power from health informatics. Because like I said before, you don't know what you don't know. So I would say that this is a really good step, because the other thing that from the Society of therapists, forgive me if that's the wrong title. You don't know what you don't know. So you don't know how many physiotherapists has like not even thought about this stuff, don't know about this stuff, and have never used it in practice. So maybe one thing you could do as part of the feedback on the course is have that, you know, ask the question, did you know any of this stuff before you did the course? Or maybe have a survey before the course and after the course and see what the difference is. Voila. I think that one of the things that you'll really sort of get out of us as you know, PPIE people and you know, what do you call them? Allies. That's the right word. I would say what you would get out of us would be sort of educating the practitioners into how do you talk to the public, because there's lots of technical terms used, and one of the reasons why probably some of the patients come away sort of scratching their heads is because of that. So one of the things that Francesco is obviously part of the same thing, but I've written a number of layer summaries now, and just making the language accessible and simple to use can be quite transformational. I would, and I didn't, I'll look at the slides and I'll get back to you, but I would like to see that as a module, because I think that's quite important. And also, you know, some people are visual, some people are words, some people are statistics. So there's how do you integrate all that for the patient? So that's what hopefully you'll get out of us as a collective. And I think that as much as education, etc., it's also about how do you disseminate that information once you've learned it or absorbed it. You need to be able to translate it for the patient. So you see what I mean? So I think all that is really important. Otherwise, you might just sort of end up in a position where, you know, you've done all this brilliant work, you put all the effort in, and it's still not working for whatever reason. So I think there's that extra step of like, you need to be able to translate everything that's going to be learned and disseminated back to the patients, because like you said, without the patients there is no data. So it's got to be a virtuous circle, and I think that's what always is the bit that's forgotten about in a lot of healthcare. It's like, it's a big circle. It isn't a two-way or even one-way conversation. It's a circle.
Yeah, I fully agree, Anthony. It is. It's about the. I was going to say the multiple uses of data, and that'd probably be an unhelpful thing to say. It's about sharing appropriate knowledge and information with the people that need to know it, that and in a way that allows them to use that and apply it in their setting. So yeah, absolutely. In terms of the course, we need to practice what we preach. So we absolutely will be gathering data about usage, about the impact that it's had, and then using that to improve and you know, do things differently. We absolutely will be presenting data and new information in different styles to make sure it works for all our learners, because they'll all be approaching it through with different lenses as well. So like you said, some will be visual learners, some will be, you know, will prefer text, some will prefer experiential learning. You know, the allied health professions, the 200,000 people across the UK, whereas as you know, diverse in terms of our learning styles as any other 200,000 strong group of people. So we need to speak to that. We have a lot of our members who are neurodiverse. So again, we need to be able to find different ways that our learners can access this. But that speaks to the patient population that we're working with as well, who come in with different levels of health literacy as opposed to digital or informatics literacy. And part of the stuff about we're doing is how we share information to have an impact. Well, we need to understand who our stakeholders are. Our stakeholders might be NHS England or the Scottish Government or employers or whatever else. Our stakeholders might be the local tennis club or the local bowling club or the miners welfare club or whatever it might be. But we need to present information to them that's important to them and in a way that makes sense and is accessible to them. And that isn't a one-size-fits-all thing. So part of this course is starting to think about how we deliver that in a better way. Noticing the time, so I'll briefly summarize if I might, and then Brenda, if you would be able to get your question to Chris, then I can respond to you by email if that's all right.
Yeah,
and,
it was yeah. Let me just say what it was about. Sure. I was going to ask Chris whether this is perhaps a different topic, but data covers a lot of things. And Francesco was saying about what data goes into, I mean, a KPI and other involvements, quite often asked about, say, an application, but how important is it? Who it's going to? Sorry, Francesco was talking about reviewing applications, and I don't know the terms on which these applications get evaluated.
Yeah.
Is it all from the patient's point of view? Is it from academic knowledge? The university wants to increase that. And I've also heard rumours, and I'd like some feedback on this, about what a lot of them are really looking for now is the benefit to the NHS. And all these three factors are very much intertwined, because a benefit to the NHS is eventually a benefit to patients. But I get the impression from what I've heard on the news and politics and that the NHS is in such a situation at the moment that they're not looking at what benefits patients. All they're looking at, or the main thing they're looking at, is what can save money and what can save resources, especially staff and expensive equipment, the NHS. Now, I had somebody ask me a couple of days ago about, I didn't get my application reviewed. And I feel like saying, well, as far as I know, they get a lot of applications and they're all good, but they've got to pick, quote, best. And what I'm asking about is how do they judge the best and what criteria? And is this relevant to Euan?
I think it's relevant to what Francesco has said, and I think it's something we're going to have to pick up on in a separate session. So if we could bring together people who do the reviewing process and say, how do you decide what is worth funding or not? I think that would be really interesting.
That would be excellent. Yeah.
So I want to add that definitely to my list. It's probably not. It's moving a bit on from Euan. But in terms of what you were after, Euan, I think first of all I was going to say it's obvious to me we've only scratched the surface here. There's loads of opportunities I think that people could use work with you and that's their knowledge and experience and intelligence. So if you would, I'll send them out to everybody who's been on the call today. And if it's okay with you, I'll also include your direct email if they want to make contact with you. Equally, Alice and I will also keep in touch with you, and it may well be we need another session. It may well be that he wants to recruit others, so we could keep. We could look for that recruitment as well. We could also make sure that anything Euan does in terms of his project also goes out to our members in the newsletter, so you'll all hear about stuff, even if you don't want to stay directly involved. But I think it's that initial who wants to work more with you and find out more. I've already heard enough and I've seen enough in the chat to demonstrate there's a real appetite there to work much more closely with you and to see what this is about, to see where you can help. I think it's probably a fair summary with people nodding at me. Euan, is there anything else you wanted to say as a parting shots there?
Main thing is thank you. Thank you for having me. I've come away with some things to think about. Lots of things to think about, and that's super important. What I'm also hopefully coming away with is some people that we can involve in the process as we go further on. So this isn't just one opportunity to benefit from your expertise. And what I hope I've also done as well is not stir the pot, but certainly raise the temperature in terms of further appetite to be thinking about how we use data, not just in physiotherapy, not just in allied health, but across health and social care, to try and demonstrate in good practice, drive up the quality, the quantity of things that we're able to do to try and address all the difficult things that we're facing right now. And geez, oh, do you know, when was the, you know, we've never had to look quite so far for our challenges in health and social care, have we? So, do you know, it's been fantastic. There's been a couple of bits and bobs in the chat. Susan reached out. Susan, my email's in the chat. Please email me, and I'd love to speak about that work that's going on at Uni of Liverpool and see if there's anything I can do to help with that. And then I'll share some more information with Chris, and then he can share it with you all at a later date and see about getting some formal input into the work that we're doing over the next few months. That would be fantastic. But yes, thank you very much for having me. I've really enjoyed the last hour. I've gained lots. So thank you very much for that.
Thank you. And thanks everybody as well for your patience. I'm sorry it overran a little bit, but I think it was a fascinating topic. Thanks again.
Thank you all.
Have a good weekend.
Excellent, thank you.